I've been giving the title Imaging and Chronic Groin Pain, a lot of which Sonia's already covered. So we'll look at what we're going to see in the next 25 minutes or so. And I'm going to show some images of the anterior pelvis anatomy in relation to radiology and what we see at radiology. I'm briefly going to mention acute injury, but that's already been covered as well. And really I'm going to focus on looking at chronic change, or what we probably should call overuse injury in these athletes. And I'll look at some of the imaging techniques and also some of the limitations in relation to what we've just heard from Sonia as well, but also in my own experience. We don't really need to talk about biomechanics. That's been covered this morning, and we just know that there's a lot of shearing forces going through the symphysis and anterior pelvis, and the pelvis has to tilt, obviously, as well, going through the repetitive range of motion, which you've heard. If you look at some anatomical texts, you'll see quite discrete attachments of the adductors, the rectus, and the inguinal aponeurosis, but we know in reality that these tissues all merge and overlap with each other, which again gives us quite a lot of the problems that we find with clinical examination, and also in terms of imaging this area and defining exactly what is the structure we're looking at that's normal or abnormal. So really we're looking at forces going through this region here, overlapping tissues, and what can we see on imaging. And I'm going to focus mainly on MR imaging, and we'll also mention ultrasound. So if we look at the midline, this is the level of the symphysis, the disc, and you can see rectus abdominis is wrapping around the front of these tissues and the front of the disc itself. So it's merging with those tissues. So it's not discretely attached, separate from the symphysis pubis. If you go slightly sagittal to that area, you can then see that we have the bone, we have the capsular tissues here, and then we have rectus abdominis and adductor longus, again merging in front of this area. And this seems to be the main area, in my experience anyway, that we see the major abnormalities in symptomatic soccer players. And again, if we take this analogy to the rest of sports medicine, typically where we see injuries or overuse injuries as well are junctional areas where tissue, different types of tissue merge, such as the muscle and tendon and muscle injury. You can see this on ultrasound, but it's much more difficult. And again, this is an ultrasound image which we can follow rectus abdominis. We've got the pubis bone here, we've got the capsular tissue, and then we've got the rectus abdominis and adductor longus. But as I'll show you, a number of the changes that we see in this region are usually low-grade edema, and detecting that on ultrasound, where there's no acute structural abnormality, can be really difficult. What you can see quite nicely on ultrasound is the symphysis pubis cortical surface. And this is normal appearance. This is the irregularity that we see. And again, it's the apophysis is the area that I'll show you in a moment. So this is the apophysis, or the growth plate of the pubic bodies. And you can see here, and this is a 16-year-old, and this is the pubic bone. We then have the calcification of the apophysis with some enchondral ossification beginning. So this is the growth plate. And not unlike the iliac crest, it seems to be one of the last growth plates to fuse. So I think in Andreas's study, it might be interesting to know if there's any difference in your 18 to 21-year-olds versus your 21 years olds onwards for acute injuries in this region, because this quite often doesn't fuse until you're 21. When it does fuse on MRI and on other imaging techniques, you can get this difference in bone marrow signal. So you can see here, this is fused with a relatively sclerotic appearance. It's lost its bone marrow fat signal here, but again, this is completely normal. So this variation can be quite marked. And if you do trauma, we do a lot of trauma in our centre, and so we've got lots of young males who've had accidents, usually in their cars. And again, this can catch people out when they come down to the symphysis pubis. This again is the growth plate, and again, this is completely normal. And again, this is a 21-year-old, and you can see the growth plate quite nicely wrapped around the front. This is a sagittal sequence, and this is an axial sequence, and you can see it just stuck on the anterior and medial aspect of the bone, and it hasn't fused yet. And again, similarly, in ultrasound, you can see all these steps, and again, people get excited about this, but it's completely normal and is non-discriminatory in terms of symptoms. As you've already heard from Sonia, another area that's doesn't seem to be that discriminatory on imaging is remodeling, so disc extrusion, bony spurring, as you can see here, irregularity in this area, doesn't seem to correlate well with any current symptomatology and can be present from quite an early age in elite soccer players. So again, from 18 onwards, you can start to get your symphysis pubis looking like this, whereas in non-athletic individuals, it will be seen slightly later in life or in postpartum women. So let's come back to the area we've just reviewed in terms of anatomy. We're looking at stresses through this area, and we're looking for pathology in this area. So what MRI technique should we use? And this is the MRI technique we use in Leeds, and we've used it for quite a few years. And we do coronal and axial large field of view. So by large field of view, I mean we cover the entire pelvis, and this gives us an idea of other things going on in the pelvis, so we can look for acute muscle tears, acute bone injury, if the clinical question isn't that specific. Then we want to focus down on these areas that we've just looked at. So we're looking at really at the symphysis pubis and the tissues immediately around it. So we want to do small field of view, and we, in Leeds, we oblique it to the superior pelvic rim to get thin slices through this area. So it doesn't really matter if you don't oblique it. You can do it whatever obliquity you want, as long as you do a small field of view and thin slices, because if you do thick slices, you can be in the pathology and then out, and it's difficult to tell. And traditionally in Leeds, we always gave gadolinium. And when I arrived as a consultant, the corridors were awash with gadolinium. Everybody got it, no matter what you had, and it was the same for our athletes as well. And really, there's a number of reasons for that. There's laziness. People just gave gadolinium for everything. But also, at that time, certainly the MRI scanners and the coils that we put on patients to get good images weren't as good as they are now. And getting a nice anatomical image using T2 weighted imaging in this area was really difficult. And you got round it by doing T1 weighted imaging, and then you gave your gadolinium hoping that the injury would enhance. So really, as we've progressed with newer scanners and now with 3T, we rarely need to give this, but there are some areas where there is still a role for it, and I'll show you an example of that. So these are what these oblique axial images look like. You get like a lengthening of the symphysis pubis, and you can see quite nicely the pubic bodies with that irregularity and sclerosis of the old apophysis. And you've got the tissues that we were looking at, that junction of the capsule, the adductor longus and rectus abdominis sitting at the front with a bit of fluid in the joint. So before we move on to chronic strain, well, one other area that you can assess on your MRI when you get it is bone stress. And again, it's not uncommon to get this in younger players. You can see here there's bone marrow edema. But unlike other examples I'll show you later on in chronic pain, this is quite asymmetrical, much more marked on the left side. This player didn't rest. They kept him training. He was an elite academy player, and he progressed to get stress injuries through the sacrum as well. So again, this kind of supports this pelvic ring theory for that sort of injury. Acute soft tissue injury I'm not going to cover because I'm just going to show you one example, but we just know it's completely different, and again, forgive me, our radiologists aren't always aware of that, but it's completely different presentation. It's much more severe, and really you can use MRI or ultrasound, as Dr. Nabil nicely showed, because you've usually got an acute tissue injury with an associated hematoma, and that's what you're looking for. So here's an example. These are our coronal large field of view images, and you can see already there's edema here in the lower rectus abdominis, more so on the right, coming through into the adductors, and you can see there's an avulsion of the adductor longus here coming off compared to that nice, you can see that continuous structure almost running across the front here, and here it's disrupted acutely with an avulsion. So that's acute injuries. Let's move on to chronic injury. And if we look at groin pain, there are a number of causes. And again, it's already been largely discussed this morning. We've got hip iliopsoas, we've got hip tomorrow to discuss. But if we're talking about these patients with athletic groin pain, clinically, in my practice, this is the sort of clinical diagnosis I get sent by my referrers. And these can be club doctors, club physiotherapists, and they say, groin pain, query sportsman's hernia, or groin pain, query osteitis pubis, symphysis pubis change, or groin pain, query adductor strain. And as has already been alluded to through all the previous talks, this is the problem. We don't have a standardized, accepted terminology, And there are a number of studies showing that if you're trained to examine for inguinal canal bulging or superficial ring, every single athlete you see with inguinal pain, you'll probably give them that diagnosis, where conversely somebody else may diagnose them as an adductor. Symptoms, I don't need to tell you, you've already had all that. And really, just to reiterate what I've just said, there's no accepted terminology. And are we looking, as nicely shown in Per and Christian's paper from this year in British Journal of Sports Medicine, are we really looking at multiple pathologies with all these surgical studies that have been described, usually consisting of 8 to 10 patients, where they do, dissection of the inguinal canal or something like that? Or are we really looking at different names for the same process? And I must admit, I think we're looking at the same process with different people calling them different things. And again, from Per's paper and Christian's paper, they kind of said that the majority of things they saw on clinical examination were adductor related. So what are we talking about when we say chronic injury? Because again, that's controversial. If you look at rheumatology or you look at any other medical condition, we're usually thinking of 6 months. Then athletes, you're thinking 6 weeks. And certainly some of my clinicians in Premiership football team, if it's more than 2 to 3 weeks, they consider it chronic. If we look at the terminology and how confusing it is, people have described osteitis pubis, adductor tendinopathy, enthesopathy, abdominis dysfunction, whatever that means. And then if we look at the inguinal canal, this is where we have a lot of small surgical studies talking about micro tears, incipient hernias, actual hernias, and so on. And this is where you get the terminology Gilmore's groin, which is very famous in England. Sportsman's hernia, which again is confusing because by definition it's not a hernia. So if we look at what we can see on imaging, I can't go through all the clinical and radiological confusing terminology in 25 minutes, but let's see what we actually see on imaging. And for me, if I try and simplify it, we see 2 main patterns in symptomatic and asymptomatic athletes. And we've got, as you've already heard very eloquently from Sonia, we've got the bone marrow edema, and we've got the change in the parasymphyseal tissues. And these are the 2 patterns that we see on imaging. So if we look at bone marrow edema, it's been described as osteitis pubis, largely in the Australian literature. And again, there's controversy over how you define that in those papers, because they talk about seeing instability around the symphysis pubis. And I must admit that we don't bother with x-rays at all, really, in clinical practice, because all you see is the remodeling, the sclerosis doesn't help you at all. And we rarely ever see true instability where you do like flamingo views. So the other pattern that we see is in the adductor region. And again, you can criticize me for saying adductor, because it's really this capsule merging with the adductor and rectus abdominis at the front. And this is where we see edema and where this cleft sign that you've already heard about has been described. So if we look at pubic bone marrow edema, you can see 2 patterns, as I've already said. And this is the pattern that we typically see in younger players, this kind of symmetrical pubic body edema and this halo of edema in the soft tissues, but no specific disruption of any soft tissues. It's like a halo around it. You can see fluid, you can see that remodeling, which again doesn't help us, and this bone marrow edema. And this seems to be present in younger players who have usually academy players who have been overtrained, and all that happens is we do the scan, we say, oh, that's what we thought, and they shut the player down. It's almost like a stress injury through this area. And again, one of the examples I showed you earlier, they didn't shut him down and he proceeded to fracture. So again, we can't see fluid in the cleft. It doesn't really help in the symphysis itself and not the secondary cleft. Sorry, that's confusing. And again, this will resolve with shutdown 9 times out of 10. There are descriptions of people who do steroid injections into this area, but really that's just a painkiller. So what are the other changes that we see? And these are the changes that we typically see in older athletes. And by older football players, unfortunately, I mean anybody over the age of 21. So this is the cleft, where you see, originally described in the paper by Brennan, and you can see the primary cleft, they called it, in the joint, and then the secondary cleft here. And they called it a cleft because they injected all their patients with radiographic dye and saw this dye go into here and then leak out the side. So they called it a deficiency in the joint or a secondary cleft. Just out of interest, a lot of the controls they had in their study were actually rowers. So again, I've never seen a rower with athletic groin pain. So the fact that they found no similar findings in their control group probably isn't a surprise. So this cleft, I think, is the same as what we're seeing on these oblique axial sequences. As you can see here, we've got the joint, we've got the nice low signal soft tissues on the right, and on the left you can see fluid going into this injured tissue on the left, where we've got this merging of the adductor longus and the capsule and so on. And if you want to give gadolinium, as we do, you can see it also here. You can see this apophysis now enhancing. Doesn't enhance on the right, and you can see this is tissue here all enhancing. But it doesn't really add a lot because you already know that this is abnormal in this case. Here's another example of a cleft on the left, and again they found the cleft localized to the side of symptoms in their study. And again, here it is on the oblique axial. You can see the low signal continuation of soft tissues, and here at the junction of the bone capsule and adductor longus, you can see again this thickened extension of fluid into the area. So what was that proviso I gave you about gadolinium? Well, occasionally it catches me out. So if you look at this player, you can see they've got a cleft on the left, they've got a cleft on the left on their oblique axial. So what side have they got their symptoms on? Well, if you looked at the literature, you'd say left, yeah? And, well, you can argue, does it really matter? They're going to get the same treatment anyway. But so this patient had gadolinium, and lo and behold, look, that area doesn't enhance, and the tissues around it don't enhance, but this area here, with a slight bit of edema in hindsight at this junction of the bone, and this player had right-sided symptoms. So why is that the case? Well, I don't know. I mean, is it the pathological process has produced granulation tissue that isn't edematous, but it enhances because it has vascularity? Probably, that's probably what it is. But it's probably more of academic interest than really clinical practical issue with what we do. And here's the final case. I'm just going to show you again just an example of what these oblique axial images look like. And again, here we are, the symphysis pubis. You can see, look at this apophysis has fused in this way. So it's like two mushrooms sitting here, the sclerosis. Again, doesn't mean anything. There's no edema. You've got some tissue at the front. You've got fluid in the joint, which is kind of seeping out a bit there, maybe. And as we come down, you can see there's a little hint of edema here. So what? Carry on. And as we go down, you start to see low signal on the left and high signal on the right. And as we come down, you can see there's more edema here and edema in the junction. And again, this player had right-sided symptoms. So there's no disruption there, but there is edema. So what else can we do as radiologists? Well, again, this is another controversial area, and it's not really an area we've touched on as yet. But in simple terms, all we can do as radiologists is really give steroid or any other chemical agent that you wish us to give. We can deliver it in a way that ensures it's delivered where you want it to go. Does it need to go there to cure the patient or to help pain relief? That's a very debatable point. So those papers I talked about where they inject dye into the symphysis pubis, it's a very low volume joint, as you may or may not know. So putting some dye in to confirm you're there and then trying to put steroid in afterwards is often very not rewarding because you can't get it in. So we use ultrasound to get into the symphysis pubis. So we have the patient supine. There's the disc. There's the needle coming in through rectus abdominis, and here it is. And this is the disc. And you can see the injectate just flowing through that area. And we used to be really clever and try and inject the adductor longus where we saw the edema on our MRI scan. But in fact, when you inject into this area, quite often the player will say they feel the bubbles and the fluid going into their side that's symptomatic. So it's probably going out through that cleft or whatever capsular disruption into that area. So we've stopped doing targeted injections. We just do symphysis pubis. But again, the literature a lot of it doesn't have controls, and whether we're just giving a long-acting pain relief and whether we're actually doing any other good, I'm not sure. One thing not to be caught out with if you're looking at images is patients who've had surgery, because they will always have scarring, but they will also have muscle changes and capsular changes. So this patient has had a right adductor release. So this change we're seeing here is completely normal for that patient because they've had that cut at surgery, and this edema that we're seeing in the muscle is denervation. So there's been damage to the muscle at that point. So that isn't an acute injury. So if we move away from areas where we can see changes, i.e. in the symphysis pubis and those tissues immediately around it, let's talk about the other area, the inguinal canal. And again, I've already said that there's a number of studies looking at this. Some people call it posterior wall weakness, rectus abdominis micro tears or dysfunction, conjoint tendon tears, external oblique tears that extend to the superficial ring. So people who feel a dilated superficial ring say, oh, that must be a superficial tear. External oblique tears that don't extend to the superficial ring but are presumed to cause neuralgia or neuralgia itself. And the problem we have with all these techniques is that we don't really see the pathologies described in these surgical series on imaging. Now, one area a few years ago where people got very excited about was posterior wall movement. And there was a study by Orchard et al. In 1998 that described Australian rules football players where they kind of saw this bulging of the wall, which I'll show you in a moment. And they said, well, this is because the wall is damaged, it's lax. And quite understandably, they hypothesized that this bulging was pushing on the nerves and causing pain. But if you read the paper quite carefully, even in that paper, it wasn't a reliable correlation. They found it in people who didn't have symptoms, and they found it in players who'd had the operation to cure it post-operatively and were asymptomatic. It was still there when they ultrasounded them afterwards. And that's really been shown in subsequent papers. Steele produced one in 2004 where they didn't find it a reliable correlation. And we did our own paper a few years ago, and these weren't in athletes, these were patients with groin pain where they couldn't feel a hernia. And again, we didn't find it a reliable correlation. So what does it look like? Well, if you're looking at the inguinal canal in its short axis, this is a sagittal anatomical plane, you're really looking for the peritoneum and bowel to push in and compress the canal, but there's no actual defect or hernia. So there's no hernia. And this is what it looks like on ultrasound. Here we have the canal with the tubes coming out at you, various blood vessels and cords. We've got psoas here, and here we've got bowel and peritoneum. And when the player strains, it causes compression. And again, we've done a series of 34 asymptomatic, or largely asymptomatic, young academy footballers over 4 years, and they had a wide variation in what happened, and it didn't relate to symptoms. And you can have the canal rotating as they strain, you can have it staying where it is and expanding, or you can have it being compressed, and it doesn't seem to make any difference. So people will say, well, ultrasound's useless anyway, it's user dependent, why don't we do MRI to look at this area? And this is a non-athlete, obviously, because we can see lots of fat. And the reason I'm showing you this is that we can see the anatomy really beautifully. So here we are with the oblique musculature. We've got the coming into the symphysis pubis, and this is the inguinal canal with fat in it. And if we go along another image, you can see the contents of the canal leaving through the superficial ring. But we can MRI these people all day with edema, with gadolinium, whatever you want. We don't pick up edema in these aponeurotic structures or even in the soft tissues around it. It seems to be those areas I showed you earlier on, the symphysis pubis and the capsular junction at the front. So these sort of tears, this is somebody where we have got a bit of edema in the inguinal canal, and this is because they had surgery 2 weeks ago. So they had an inguinal repair, and this is edema from the inguinal repair. What about asymptomatics? Again, I'll briefly touch on this, and I'll just show you what our experience is. This is an athlete who came for a hamstring origin assessment, and you can see that they also have a left-sided cleft, and they're completely asymptomatic. we're in the process of publishing a paper where we took 34 elite academy soccer players. So these are premiership clubs. There were 5 premiership clubs from England, 16-year-olds, and we followed them over 4 years, where we gave them MRIs and ultrasounds. And even with this number here, it's too small to reach statistical significance. And what we did find, though, is that asymptomatic players, as Sonia said, could have bone marrow edema that was rated as severe. They could have a cleft. Again, a lot of the papers say this is specific to current groin symptoms, but it isn't. And they all had remodeling, and they all had canal movement of some description. So these features are non-specific. These features can be present in asymptomatic athletes, it seems, and the only thing that seems to be a discriminator is the severity of changes that you're seeing. So in conclusion, I think if you've got an acute injury, as you've already seen from the previous talk, MRI or ultrasound is good. If you have an actual hernia, which is extremely rare in this athletic population, you can do an ultrasound. I mean, Sonia mentioned in her literature review that they excluded people who'd had herniography. But if you look at the literature for herniography, a lot of Swedish literature looking at athletes, and they're finding hernias all over the place that were asymptomatic. So again, if you do the same with ultrasound, you'll find hernias, but whether they're the cause of the symptoms, I don't know. If you're looking for the hip problems, I would advise MRI, and typically we do MR arthrography, but I think in the future, from a purely radiological point of view, 3T will replace arthrography, and we're doing studies about that in Leeds at the minute. And again, as an anecdote, and we can talk about it tomorrow when Bruce is talking, certainly in our control population, we're finding labral tears in lots of people who are completely asymptomatic. So again, if we're looking at chronic pain in the groin area, I think if somebody comes to you and they want a specific diagnosis, they're adamant that they believe in this diagnosis, I don't think we can detect a correlation on imaging, and it remains a clinical diagnosis. What you're doing imaging for is to exclude other causes. I think if we're looking at the symphysis pubis and the junctional tissues around it, MRI is the way forward, and ultrasound isn't really sensitive enough to pick up those edematous changes I've shown. Thank you.